Good afternoon. Thanks for joining us at the Prevent Blindness Focused on Eye Health webinar series. Today's webinar is titled Building Eye Care Access Through Collaboration with Indigenous Communities, Learning from the 2025 Jenny Pomeroy Award for Excellence in Vision and Public Health recipients. My name is Mitch Brinks, and I'm the Sterling H. and Anna Marie Tebbetts Professor of Global Ophthalmology at the Oregon Health and Science University. I'm also a member of the Prevent Blindness Board of Directors and chair of its Public Health and Policy Committee. I'll be moderating the session this afternoon. Today, we'll hear from the Dean McGee Eye Institute, recipient of the 2025 Jenny Pomeroy Award for Excellence in Vision and Public Health. The Dean McGee Eye Institute will share lessons from its work expanding access to eye care across all 77 Oklahoma counties, especially in rural and underserved communities, as well as in Indigenous communities, while also contributing to global vision research. The discussion will highlight how other institutions can adopt scalable models that serve both clinical and public health priorities in eye health. Dr. Judy Goforth Parker, Chickasaw Nation Commissioner of Eye Health of Health Policy, will offer insights on how the Chickasaw Nation is partnered with the Dean McGee Eye Institute to develop a strong partnership between eye care providers and Indigenous communities, leading to improved vision health outcomes. I'd like to first thank our sponsors of the Focus on Eye Health webinar series, our platinum sponsors, the Alliance for Aging Research and PHRMA, and our gold sponsors, Amgen, Bio, Bright Focus Foundation, Collaborative Community on Ophthalmic Innovation, and Genentech. Now let's get to the award. The Jenny Pomeroy Award for Excellence in Vision and Public Health is named for Ms. Jenny Pomeroy, who served as CEO of Prevent Blindness Georgia from 1996 until 2013, and who was a champion for the role of public health in vision and eye services programs. The annual award recognizes an individual, team, or organization that has made significant contribution to the advancement of public health related to vision and eye health. The awardee was selected by a volunteer review committee, including ophthalmologists, optometrists, and researchers who all have a public health focus. Now, our recipient, the Dean McGee Eye Institute, was selected for this year's Prevent Blindness Jenny Pomeroy Award for its significant contributions to vision and public health research. The Dean McGee Eye Institute was formed in 1972 in Oklahoma City and dedicated to serving all Oklahomans and the global community through excellence in leadership in patient care, education, and vision research. Since the dedication of its original building in 1975, the Dean McGee Eye Institute has grown into one of America's largest and most respected centers for medical and surgical eye care, with more than 200,000 total patient visits annually from all of Oklahoma's 77 counties and the surrounding region, and 9,000 major surgical procedures are provided by the Dean McGee Eye Institute each year. Please welcome Dr. Michael Siatkowski, who will accept the award on behalf of the Dean McGee Eye Institute and provide the award presentation. Michael?
Thank you very much, Dr. Brinks. I'd like to share with you all this lovely plaque that we have that commemorates the award. This plaque will be placed in our library and reception space for many, many people to see as they come through. We're very honored and proud to receive this, and I want to make it very clear this award has very little to do with me. It has to do with the people who had the vision to form the Institute, the people who've worked here over the last 50 years, and the amazing staff of over 300 people we have, as well as our very outstanding board of directors. So it's a pleasure for me to share with you a little bit about what's happened with Dean McGee since our inception and what we're looking forward to in the future. Next slide. Our mission statement is that we are dedicated to serving all Oklahomans and the global community through excellence and leadership in patient care, education, and vision research. Next. As Dr. Brinks said, our story begins in the early 1970s. Mr. Dean A. McGee, pictured on the left there, was an oil magnate. He founded Kerr McGee Oil Company with Robert Kerr, who became a noted Oklahoma politician. And in 1971, he suffered a rhegmatogenous retinal detachment. This was repaired by Dr. Tullis Costin and Dr. Tom Akers, who were at the University of Oklahoma Department of Ophthalmology. Back in those days, ophthalmology was a subdivision of surgery, and retinal detachment repair had never been successfully performed in the state before until Mr. McGee had it done. Needless to say, he was very appreciative and asked, "What can I do to show my appreciation?" And their answer was, "We need to have an eye institute like Miami and Los Angeles and Houston did, so people from our state won't have to leave to get good care." So Mr. McGee mobilized city leaders and state leaders and philanthropists at the end of 1971, and 4 years later, on December 4th, 1975, the Dean McGee Eye Institute opened its doors. At the time, it had 3 doctors and I think 2 residents who were just starting, and you'll see how we've grown over the years. We had a major expansion in 2011. It was named after David Park, who was a prior CEO of the Institute and then became the CEO of the American Academy of Ophthalmology. And we're particularly proud to be sharing this award during our 50th anniversary year. Next slide. Dean McGee is very visible throughout Oklahoma City and throughout the state. We have a strong name brand. You will see us in the newspaper, hear us on the radio, see us on TV. Our doctors are out doing explanations, public service, and promoting the word of we're here to help the people of Oklahoma. Next. I like to say that there are a few things that only Dean McGee is doing in Oklahoma, and they really boil down to our tripartite mission. The first and most important has to do with direct patient care. You'll see that we have a lot of doctors here, a lot of ophthalmologists, a lot of optometrists, and we have a spectrum of diagnostic and therapeutic equipment that doesn't exist anywhere else in the state. So we are by far the most comprehensive eye care provider in the state. In addition, it's been part of our mission since day one that we don't turn anyone away regardless of their resources or their ability to pay. We hold firm to this mission even in difficult financial situations. So from a public health standpoint, we're a crucial part of the fabric of our entire state, because without us, people would either have to leave the state to get care, or worse, they wouldn't get the care that they need. Education is a very important pillar of our mission too, and you'll see shortly how we have been involved in that. But from a public health standpoint, it's really important. You know, Oklahoma is an underserved state, and we take great pride in training the next generation of ophthalmologists. Our state has about 110 ophthalmologists, and the vast majority of them in some way have been connected to Dean McGee. And of course, vision research. Although there are other places where vision research is done in the state, we have the largest collection and the most broad collection of equipment to do high quality research on, and the most amazingly trained and successful vision researchers. And when you think about it, conducting research is an important part of public health too, because especially in the face of a provider shortage, if we can come up with new treatments, or better yet, even preventative ways to address visual disease, it's great for public health. Next. This is the group of providers that we have. You see, we have a very full, complete spectrum of subspecialties in ophthalmology, obviously lots of cataract surgeons, but everything else is well represented, including some things that are hard to find, such as uveitis specialists or ocular oncologists, or those who make prosthetic eyes. Next. The building on the top left is where I'm speaking to you from. And by the way, for those of you who are not able to see me, I should tell you I am a 61-year-old kind of blonde gray guy who's slightly overweight and slightly balding, but very happy to be here. And at the Health Sciences Center, most of our patients are seen there. And right across the street, we have an ambulatory surgery center. And down the road, a block away, we have a satellite at the Children's Hospital. The satellites down below are farther away. Northwest satellite means it's in northwest Oklahoma City. It's towards the end of the city limits in northwest. Edmond is the first major town to the north of Oklahoma City, and Lawton is 100 miles southwest of us. And so it's in a more rural area, although the city itself has a big military population with Fort Sill there. Next. We're a busy place. Currently, we have 34 ophthalmologists, the vast majority of whom also do surgery. We have 7 optometrists, 5, what we'll call them practice extenders, which include an orthoptist, contact lens specialist, ocularist, and a physician assistant. Last year, we had just over 210,000 total patient visits in calendar year 24. This represents almost 70,000 different unique patients. This puts us in the top 5 for volume of patient visits of eye institutes in the country. Last year, we performed over 9,000 major surgical procedures. That means surgery done in an ASC or in a hospital. If you would add what's done in minor surgery in the clinic and, of course, the injections, this is many, many thousands more. So we're proud to routinely serve patients from all the counties in Oklahoma and all of our 7 bordering states, as well as from across the country as well. Next. I told you that providing care regardless of ability to pay is a crucial part of our mission. Over the last decade, we have rendered over $12 million in uncompensated care, which includes more than 2,500 surgeries of all types, not just cataract surgery, any type of surgery, and many, many outpatient visits. And again, we are just so wedded to the mission of not ever turning anyone away based on ability to pay. It's part of our core, and it's great that everybody here feels the same way. We're not in this to make a profit. We're in here this to serve the state, make the state of Oklahoma and its citizens better and better for the future. Next. Education, very, very important to us. We're proud of our residency program. We're always ranked in the top 10% of residencies among public universities and in the top 20 of residencies nationwide. Next. We have a 4-year residency program with 5 residents per year, so there are always 20 floating around. We also do fellowships, subspecialty training after residency. We have fellowships in cornea, glaucoma, retina, neuro-ophthalmology, and global ophthalmology. And we are embarking upon starting a fellowship in oculoplastic surgery. We have a lot of involvement with the medical students. We live in an age where many medical schools in the United States are cutting out ophthalmology because they don't have time for it. But we're happy to say we have significant contact with students in all 4 years of medical school. We do a lot of things for the community, you'll see in a little bit. And we also realize that we need to learn from others. So we have 6 or 7 times a year, external professors come in, not just to teach our residents, but to share their work and their ideas with our faculty as well, so we can get better. Next. Our residency is very competitive. This year we had 650 spots, applications for our 5 spots. And so if they get an interview here, they're in the top 1%. Since we've opened, we've trained almost 300 residents and fellows. 36% of our residents stay in Oklahoma, which is remarkable because it's only been about 18 or 20% of our residents who are from Oklahoma to begin with. So double that number is staying in the state afterwards. And that's extremely important given the provider shortage that we have in this state. Only a few of our fellows have stayed in Oklahoma, often because they have jobs elsewhere when they come here or they're going back to be with their family. But so we do have a significant local as well as national footprint. Next. Research, again, very important over the last decade. On the average, we've had $4 million per year of grant funding from the National Institutes of Health, which is, very remarkable, especially in the environment today. Next. We have 8 full-time PhDs who are doing research as principal investigators. I'm very proud to tell you that as of December 1st, all 8 of them will have funding from the National Eye Institute, which is really remarkable today. We have another PhD person who does some ancillary work and research, but really is in education. Is actually directing part of the education, and not just vision, but also research in infectious disease for the College of Medicine. And we also have grad students and a postdoctoral student. Next. The things that we focus on in research, the 3 big areas are infections of the eye, like on the cornea, as well as with inside the eye. genetic eye disease, particularly inherited retinal disease, and then the things that occur with aging are the things that cost a lot of money to the U.S. government: macular degeneration, diabetic retinopathy, and glaucoma. Our research facility has a pathology lab and diagnostic and imaging equipment. Many of the same things we do on humans, we have the equipment available to do on the mice and the rats on whom research is done. So it's a very robust research unit. Next. Part of our mission statement was also to be active on a global scale, and it's important to us. Starting in 2000, we began to go to China, to Sichuan province every year under the direction of Dr. Brad Ferris. We made 2 trips annually. This evolved in really two different foci. Sichuan province has a significant burden of cataract blindness, and so we would help them to address that. And what we really realized, one of the things that would be most effective in that is to help them sort of revise their residency training program, which used to be an observership for many, many years, where their trainees really hardly did any surgery. They just watched surgery. So we have helped them to change that to a style that's more closely or linked to what we do in the US. So they can turn out more people quickly, and people who actually have direct experience in doing surgery by the time they've graduated. Since COVID and the geopolitical things that have happened after that, we've not been able to go back to China yet, but we started in 2010 to go to Southeast Africa, to Swaziland, now called Eswatini. This is the world's only true monarchy that is left. And in Eswatini, there's the world's largest prevalence of HIV and related disease. So our teams have gone over there to take care of significant tropical disease and HIV-related disease. But we're so proud we brought things to them. For instance, a couple of years ago, we did the first corneal transplants ever performed there, and first different types of oculoplastic surgery ever done in the country. But again, we're teaching people there, not just in their country, but people from surrounding countries, Zambia, Mozambique, who come to work with us while we're there. So we're trying to leave an imprint by teaching the local people. And most recently, we partnered with some ENT doctors at the university, and we've been bringing them over here for a few months a year, the military surgeons, to teach them how to do surgery that's related to battlefield trauma that's been going on in the Russia-Ukraine war since 2022. Next. We're really involved in our community. We do lots of vision screenings at local schools. I mean, hundreds and hundreds of those. We provide free exams for diabetics in the Oklahoma City area. We have a program that will give any child a free pair of glasses if they're not able to afford it. We work with the medical students, and virtually every weekend we have a medical student-run clinic that provides free care. And one of the most amazing things we've done on a statewide basis is the tribal retinal clinics. Next. I won't take too much of Dr. Parker's steam, but I just want to give you a brief overview about it. The man on the top right is Dr. Steve Franson, who really was responsible for starting this. He was trained in Canada for medical school, did his residency here, and decided to stay in Oklahoma on the faculty. He noted that patients who had diabetes didn't get exams very often, and if they did, and if they had diabetic retinopathy, they didn't show up. And he understood that part of this was the reason that they did not want to come to the city from a place that's far away, and many of these patients were tribal members. So we had a great partner with an optometrist from the Chickasaw Nation, Dr. John Garber, who's now retired, but is one of the most amazing people that I have ever met. He would see patients down in Ada, which is about an hour and a half south of us in Oklahoma City, gather a group of patients with diabetic retinopathy, and then Dr. Franson would go down there. And in those days, he was taking a portable laser, because everything was treated by laser back then. As time has moved on, he took all his Avastin and Lucentis drugs and needles down there and started to give them injections. And they noted after a short period of time that the percentage of patients with diabetes, especially diabetic retinopathy, who were being seen on an annual basis nearly doubled, which was dramatic public health improvement. And so over time, we began these drop clinics, diabetic retinopathy outreach. And of course, we started with the Chickasaw Nation, and that's been such a wonderful relationship that exists to this day. We moved on to the Choctaw Nation, the Creek Nation, and the Pawnee Nation most recently. So Dr. Franzen retired in 2022, was taken over by Dr. Ron Kingsley, who is in the process of retiring. And so we have a great new lady, Dr. Elizabeth Fairless, who was trained here for her residency and in Utah for a fellowship. She's a member of the Choctaw Nation, and she's back here now, and she's beginning these outreach clinics. So this will continue, and we hope to expand this as time goes on. On the bottom there with the patient, that's Dr. John Garber, amazing optometrist, but a great heart to serve the people of his tribe and our state. Next. So again, we're crucial to Oklahoma on a public health standpoint. You all know everything on this slide. We're underserved in this state, but by 2035, our country is going to be significantly underserved by 30% in ophthalmologists. The prevalence of glaucoma and AMD and diabetes is really going out. By 2050, it's going to be so high that 1 in 5 Oklahomans will have those conditions, and it costs a lot, and we got to figure out what to do about that. Next, some of the things that we're looking at: AI, better telemedicine, discovering preventative disease, trying to look at omics and individualized medicine, understanding where we are better from a public health standpoint, and developing new systems of care like we did with the tribes. We have to develop new systems of care throughout our state that work in a similar way, and even within the urban area, because the need is so great. Next. So this is Dr. Paul Sieving, who was the director of the National Eye Institute when we opened our new building. And we were all honored to hear him say he felt that the Dean McGee Eye Institute was a national treasure. Next slide. I hope I've given you some reasons to explain why he might have said that. I want to thank you for the great honor on behalf of all my colleagues at Dean McGee. We're tremendously and humbly honored by this award, and we thank you for the great work that you do at Prevent Blindness. And I'm pleased now to turn it over to an amazing lady, Dr. Judy Goforth Parker, who is a great member of the Dean McGee Institute board, but more importantly is the Commissioner for Health Policy for the Chickasaw Nation. She's very humble, but she's extraordinarily educated and extraordinarily bright, and you'll be very blessed by what she has to say. Thank you.
Thank you, Dr. Siatkowski. It's very much a pleasure to be here with you today, and also quite an honor for me to have been able to serve on the board for Dean McGee Eye Institute for the past probably at least 4 years. It's a pleasure to always get to come to those meetings. And what I wanted to do today is introduce our audience to advocating for eye health with First American communities, how Dean McGee did that, how that partnership has continued, what others could do for a similar partnership, and how important it has been for our patients here in Ada, Oklahoma, to improve our eye health and also prevent blindness. I am a First American woman. I'm 71 years old. I have salt and pepper hair and dark glasses on, navy blue suit. I'm sitting in front of an image of the Chickasaw Nation Medical Center here in Ada, Oklahoma. And once again, it's such a pleasure to be here. I wanted to introduce our audience to the Chickasaw Nation. I'm not sure where you all may be, but the Chickasaw Nation is located in central part of Oklahoma in the south. We started moving here in like the 1800s. In 1907 at statehood, we were located where we are now. And I think it's important to realize that tribes are a part of the Oklahoma landscape. Oh, next slide, please. And that's the picture I was talking to you about. But the slide here shows you the counties that are the Chickasaw Nation. I noticed that Garvin County was not listed on here, and also a part of Bryan County is a part of the Chickasaw Nation. So we're more than 11 counties here in South Central Oklahoma. Next slide, please. This slide shows you the tribal jurisdiction, and you just need to realize that at the time of statehood, prior to that, Oklahoma was just filled with the Chickasaw Nation and other tribes, and we were moved here. There were 39 tribes, and we all know where we are, but I wanted you to have an opportunity to see where we are as well. We speak different languages, we have different cultures, our governments are set up differently, and we're all different. I think that sometimes when people think of a tribe, they think that we're all the same, but that's really not the case. And so we're located in almost all states, but Chickasaws are in all states of the United States. And so I wanted you just to be aware of where we are, what population we were thinking of when Dr. Franson began working with us back in the 70s. I mean, 1997. Next slide, please. I wanted to also, next slide, share with you what tribal sovereignty is and why that is important. One of the ways whenever institutes such as the Dean McGee Eye Institute begin to work with tribes, we need to realize that we are sovereign nations. We are almost like small governments located here within the state of Oklahoma. Our individuals are not sovereigns. It's the tribes that are sovereigns. Tribal sovereignty is dependent on the will of the United States Congress. They could actually limit tribal sovereignty if they wanted to. They haven't done that, but they could. And so it's a very great relationship that we have working with the federal government as we work on a government-to-government basis. Tribes can enter into compacts and contracts to exercise our tribal sovereignty. And that's a part of what happened as we started serving citizens here in the Chickasaw Nation. Let's move to the next slide. What I wanted to share with you also is that there are ways to reach out to tribes. And I think that I would like to acknowledge the work that Dean McGee did in doing this, and also Dr. Franson, as he started working with tribes. I had a colleague that helped me as we wrote an article related to how to reach out and how to work with tribes. And what we need to do is, first of all, think of some of the ethical considerations, such as do no harm and the right to informed consent. And so as we think about working with tribes, these are some of the things that we should consider. The next slide, please. And when we think about working with tribes, is that, how do you do that? Where do you start? Because if you think about Oklahoma having 39 tribes, 39 different governments, 39 different cultures, different languages, and of course, for the United States, we're talking about more than 500 tribes. So there's a lot that needs to be learned. You can visit tribal communities, learn about their cultures, attend public events. I know that as Dr. Franson was talking about the work that they've done, they've worked with different tribes. His new director, we're excited to know that she's Choctaw, but you have to just talk to the people and become familiar with them. And so those are some of the things that I would encourage, as Dean McGee did this years ago in setting up that relationship that they have with us. Next slide, please. There are formal ways to work with First American communities as well. Tribal leaders they're elected officials. They can be elected, or they could even be a lifetime appointment. And see, tribes really are different. We have tribal councils within the Chickasaw Nation. Our tribal council is actually called our tribal legislature. Our leader of our tribe with the Chickasaw Nation we term his our governor. In some tribes, they'll say it's their chief. And so you really have to understand these differences from one tribe to another. We have institutional review boards. As Dr. Siatkowski was talking about the research that is done, you think about tribes as, having actually our IRB here at the Chickasaw Nation is more than 20 years old. We're really pretty sophisticated, Dr. Siatkowski, in the types of research programs that we have developed and worked with over the years. and those require tribal approval. Sometimes it's approval through the elected officials or through the governor or a chief or the leader of the tribe, or even maybe through an institutional review board. So those are some of the considerations as you think about working with a tribe. Next slide, please. There are all other ways that I want you to consider as you're thinking about working with tribes. In our culture of different tribes that work together, you will hear the term called ITUs, and ITUs refers to the parts of the organizations that are run by Indian Health Service or parts of the tribal community that are run by the tribes themselves, and then the U's are the urbans. And so when you begin to think about reaching out to tribes to work with them, it may depend on, is this an Indian Health Service facility, such as the one in Lawton, Oklahoma? And the one that Dr. Franson reached out to in 1997 actually was under the Indian Health Service. So we were with IHS at that time. It was actually in 1994 when we started running our own facility, our own healthcare. And I'll have you go on to the next slide, please. There are also informal ways of working with tribal communities that I think that people should be aware of. There's kind of something that's said in tribal communities that once a tribal leader, always a tribal leader. And so somebody who has been elected as an official in a tribe is probably someone that you could also and always reach out to. We have elders, spiritual leaders. There are families, strong family groups that you might reach out to. Sometimes we have non-Indian leaders that are really considered as leaders in our culture and organizations. And then our veterans, of course. And these are just some entry points I wanted you to be aware of. Move on to the next slide, please. And then I wanted to talk to you a little bit about what happened as we began to work with Dr. Franson. In 1997, the Executive Summary Balanced Budget Act was passed. And with that, there was allocated $10 million. I remember the first time I heard someone talk about this, Dr. Siatkowski, and I said, is that actually new money? And they said, yes, it is. And it was a special diabetes program for Indians. Fortunately for me, I was elected as a tribal official in 1994. I had the privilege of serving on the Tribal Leaders Diabetes Committee for Indians, which is an organization, a committee that is still run that works with this grant, the Special Diabetes Program for Indians. It made a huge difference in our communities in saving people's lives and also saving their eyesight. Next slide, please. Some historical things to think about of what tribes have done. In the 70s, our diabetes care programs were established. In the 1980s, Indian Health Service established a standard for care for diabetes. And so we were early in that. In 1997, that special funding that I shared with you, that same year, and I didn't really realize this until putting this slide together, that Dr. Franson and the SDPI all happened in the same year, which is really great. He started coming to Ada, Oklahoma, and as Dr. Siatkowski said, he worked with Dr. John Garber, would come down and take care of our patients. And I think one thing that I want you to think about when you think about what was it like during this time? In the 1940s, we had hardly any diabetes. By the 1970s, it was really basically an epidemic. And so we really needed to do something. When you would walk in a tribal facility, I remember it myself when I walked into the Carl Albert Indian Hospital here in Ada, Oklahoma, and seeing all of the patients with amputations. Maybe 2 amputations, maybe 3 amputations. And then the thing that Dr. Siatkowski mentioned about that our patients didn't come for eye care very much, it was not unusual at all for them to find out that they were diabetic when they lost their vision. And that's kind of hard to imagine today, but that really was happening. Let's go to the next slide. So this is what Dean McGee shared with me, what we called a young Dr. Franson in 1997. But the relationship and partnership that they had under the leadership of Governor Anna Tubby was to begin this retinal clinic here in Ada, Oklahoma. It was so successful here that we did it in other places. And of course, as Dr. Siatkowski shared in his slides, it has grown and is being shared with other tribes as well. Here's another picture on the next slide. Maybe not as young as Dr. Franson, but it's Dr. Franson, and he's working with one of the Commission Corps officers. And as you know, or may not know, that the Commission Corps is a part of the uniformed service. They don't see combat, but they are in the IHS facilities and military type facilities taking care of patients around the United States. And they also go to areas such as, like, if there's like hurricanes or something like that, they may be specially sent to those. And so I thought, since we picked on Dr. Franson and said a young Dr. Franson, I thought, well, we might bring out a young Dr. Parker as well. And so in 2007, this shows that Tribal Leaders Diabetes Committee, which is still going on right now. And the importance of us is that we worked for and we advocated for the continued funding for the special diabetes program for Indians. These, next slide, please. There's Dr. Parker in the middle. In this slide, that it shows you people that, I mean, some of us are still around. I ran into the gentleman on the right, Mr. Freddie. He was a member of the Navajo Nation, and I saw him at a meeting just last year in Nevada, and he's still advocating for tribal health and diabetes care. And that's such an important part of the work that we do, Dr. Siatkowski. Next slide, please. And on this slide, I know there's a lot that's on there, and I think what I'll just do is I'll talk through it. You pick out parts of it that you want to look at, and if you have questions later on. But the Special Diabetes Program for Indians gives a report to Congress, because it's very important to let Congress know how we're doing, that we are making a difference, and that there is important, really, improvements in our eye care. This was done in 2024, and it showed improvements in the number of visits that we had for diabetic physical activity, nutrition. Our programs began to bring these to our tribal facilities, as with that new funding that was given to us through the Special Diabetes Program for Indians. I think it's really important to pick out on this one the amount of the retinal eye exams that were done, the increase in that, and also foot exams. But all of this was just as it provided an improvement for our tribal citizens as we were able to use those dollars. But again, I still want to go back to that 1997 date when Dr. Franson came. The funding was here at the same time, and it was a perfect blend, a perfect marriage, you might say. And if you'll go on to the next slide, please. I just think that it's important to go and think about this report that we do to Congress. It has shown tremendous improvements for First Americans, American Indians, Alaskan Native people. We have a decrease in diabetes prevalence, which is awesome, decrease in mortality, decrease in kidney failure, decreased hospitalizations because of uncontrolled diabetes, and also decrease in eye disease. And that is very important. I'm going to read, for maybe those of you who can't see this, I'm going to go ahead and read this one statement by Dr. Ann Bullock. She's of Ojibwe tribe. These improvements have huge implications for quality of life and healthcare costs. Sustained efforts in diabetes prevention and treatment are critical to ensuring continued advances in the treatment of American Indians and Alaska Native people. The SDPI, which is a special diabetes program for Indians, has been and continues to be key in this remarkable progress. And so I really am excited to have been able to share with you the latest report that we did for Congress. And that report is also very important for our continued funding. And if you go to the next slide, please. And right with this slide, I think the importance of this would be just to share with you the importance of tribal advocacy as we continue to work with Congress and work with areas of, how do we make sure that we continue to receive these fundings? We have to identify what is the area of need, identify tribal infrastructures that we work with, identify governmental structures, look at committees that we could possibly work with. There are just a lot of different avenues and doors that are open for us to be able to reach out and continue our advocacy work. We establish relationships and we determine the needed actions and we choose next steps. And Dr. Siatkowski, I believe that this does reflect on some of the early work that we were able to do as we began our program and relationship years ago. And so next slide, please. The special diabetes program has just been so important, as well as the relationship that the Chickasaw Nation has with Dean McGee. 55% had a retinal eye exam, and those examined, 24% had evidence of diabetic retinopathy. And I think I just wanted to share again that it doesn't seem that it could be a possibility that the diabetic retinopathy would be diagnosed because someone had had diabetes for so long. And so because of the funding, we've been able to, identify diabetes much sooner and then also do really wonderful exams as we're beginning to take more time to spend with our patients and do those diabetic eye exams. It's so important. The diabetic audit of 2024 represented more than 140,000 people who were diagnosed with diabetes. In 1998, it was only 11,000 patients. And so that doesn't mean we only have that many. I think it's just mean, and it shows Dr. Siatkowski what an improvement we've done with diagnosing diabetes and then also diagnosing eye disease and preventing that in our patients. The last slide that I think I'll share with you, if you go to the next one, please. Another way that you can reach out to tribes is through our Tribal Leaders Diabetes Committee and also the Intertribal Council of the 5 Civilized Tribes. This was set up more than 50 years ago. It's another avenue, another door that people can use to reach out to tribes. And I want to thank you for that. And the next slide, please, I believe will be my ending slide. Oh, no, this is the one I forgot about. This one I just wanted to share with you. Now, this one kind of is a little bit of a moving target. You know that we've gone through a government shutdown period and things are in a little bit of flux right now. But we do believe that there has been an increase in an approval for the special diabetes program for Indians. And that is another important milestone that I wanted to share. And now, next slide, please. Chickasaw, thank you again for inviting me here. And thank you for letting me partner with you, Dr. Siatkowski, and Dean McGee.
Thank you both for wonderful, touching, and really, really kind of impactful presentations of a lifetime's work on some points, some person's perspectives. It really strikes me I think the depth and commitment and probably what's evolved over all these years of this really impressive relationship. I think that's probably, seems to me, must be a necessity given the complexity of the interactions from all that goes on in the U.S. healthcare system and the complexity of eye care, and then the complexity of all the tribal governments and healthcare systems. So it's really, really impressive. I think it's pretty clear that you all are national leaders and could be an amazingly valuable resource for the rest of the country as we try to follow your lead on this front. I have a couple questions that are kind of burning questions. I guess the first one would be for Dr. Parker. Over these years, can you articulate a little bit about what your role was when this program first launched, and maybe share a few personal insights or observations from maybe the perspective of tribal councils of leaders on this program? I mean, I think there's probably been a lot of programs that have come and gone over the years, and this one has thrived, and I think that really depends on the local perspective. So maybe you can kind of paint that picture as you've been in your role and evolving over the many years of this partnership.
Thank you, Dr. Brinks, for that question. What I would think about my role has been, for a great deal, has been one of advocacy. I received my PhD in nursing from Texas Women's University in 1992, and it was on the lived experience of Native Americans with diabetes. And I remember in visiting with patients about that lived experience is that they would say, we are a diabetic people. They just expected to have, to lose their eyes, to possibly have an amputation, to have renal dialysis because of kidney failure. It was an anticipation. And I think I wanted to see that being different. And I was elected to the Chickasaw legislature in 1994 and chaired the healthcare committee. And then in 1997, when Governor Anatobi allowed me to work on the Tribal Leaders Diabetes Committee, I started that really formal advocacy. And then whenever I stepped down from that position in 2009 and started working with health policy, I just continue on. Advocacy is something that has to continually be taking place. You can't ever think that we've arrived, because you're always introducing new members of Congress to, what does tribal sovereignty mean? How are tribes different? What is the problem with diabetes? So I think advocacy, if I could just shorten it, but thank you.
Sure, great comments. It sounds like your leadership and advocacy crosses many, many fronts, as you say, from working with legislators and public health servants and tribal councils. Do you have maybe this is a lot to ask on the fly here, but it'd be interesting to hear you reiterate some of the tribal council opinions if they perhaps have commented over on the partnership with Dean McGee Eye Institute. If they liked that program, what they thought about it, and how they might have characterized the success of that program.
Well, Dr. Siatkowski talked about Dr. John Garber being I would call him a colorful individual. Everybody loved him. And so his personality made him well known, which made the partnership that we had with Dean McGee well known. Everybody knew what was happening. Of course, I was working in the facility at the time all of that was happening. And you kind of don't realize that you're watching history be made and you're watching people's lives be changed. But, my father, I've thought about him. He lost one of his eyes in World War II, and he was diagnosed with diabetes during that period of time, but he never lost his eyesight. And so I think that that's the stories that we hear. Everybody had a family member, somebody that was touched by the care that was done through the Carl Albert Service Center with the care that Dr. Franson and Dr. Garber gave to our patients. And so it was family stories. There's not a person in a tribe, hardly, I don't think that you could say, that doesn't have a family member that's diabetic. So we all have a story. So we all had that personal story of the impact that Dean McGee made on us and our patients.
Well, I can't imagine a more powerful source of inspiration than family members with personal stories. That sounds like a really powerful driver. Dr. Siatkowski, is you're at the top of a very complex and high performing eye institutes, really, hitting it out of the park on so many fronts, in the traditional kind of academic healthcare setting. And, I'm struck by the fact that you have all these residents and fellows and people moving through your eye institute, a lot of which could benefit from participating in the program. I guess I have a twofold question for you. What are your thoughts and experiences in terms of preparing learners to participate in this program, and on the outcome side of things? What do you think is the impact of those learners as they maybe move on outside of Oklahoma after having participated in the program?
Yeah, that's a great question. And I would say that, our residents, like on the retina rotation, have the opportunity to travel to the different Indian clinics throughout the state, which they often do. We also, we do a lot of care for First Americans in our Lawton clinic as well. We have a rural elective set up there. And I think that, our work with the tribes is similar to our international work, because they're kind of unique parts of our training, and they are extremely impactful to the learner, to the people in their 20s and 30s that are learning. They're trying to, they're just getting out of training. They're trying to find out a bigger place in the world for them. And I think to to be exposed to the ability to do some things like this is life-changing for them. We did a little study to look at the prevalence of our residents who are involved in some sort of real service work, whether it's to tribal nations or internationally or in underserved area, cities in the country, wherever they may be. And we found, 10 years after leaving our residency in this informal survey, over a quarter of our graduates were continuing to do this work. And so I think the best, they get a short snippet in a couple of years of residency, but it changes their mind, it changes their heart, then they can go out and do it on a bigger effort. And I'd just like to say something. I know that it's a big organization. The Chickasaw Nation is a complex, it's really a governmental entity. But in the end, it's so important the personal relationships you develop. Dr. Franson had a great relationship with all of the optometrists, with the healthcare leaders, with Judy, with Governor Anatubby. I think, if I really respect Governor Anatubby. If he called any of us at DMEG and said, we need some help with this, we'd do it right away. If we call Governor Anatubby, say, can you help us with this? They'll do it. It's the decades of trust that are built in a relationship like this you can't underestimate them, because that in the end, because we're all going to be gone, but that's what makes the programs live beyond us. And that's the great thing about this.
That's a really interesting insights, Dr. Siatkowski. I have another question for you regarding the Dean McGee Eye Institute. And it again has two components to it. So beyond diabetes, what other types of eye care work, ophthalmology work, does the Dean McGee Eye Institute participate in? Because you must see all types of pathology arise through your program. And the second part of that question is, are you working with FQHCs or other systems beyond those you've already described to expand eye care? I mean, there's certainly a lot of overlap once you get outside of the conventional clinical walls in terms of providing care beyond what you described at your clinics. So again, what kind of care are you providing beyond diabetes screening and care? And are you working with FQHCs or other systems similar to the tribal clinics?
Yeah, I'll take the FQHC first. There's a group in Oklahoma. It's called Variety Care Oklahoma, and they're at FQHC. We partner with them, and we basically have them. Anyone they refer to us, we take care of regardless of ability to pay. So we are there. They have some optometrists on staff. Anything beyond what they can handle there in the office, we have a commitment to provide that care for those people. And it's been great. They have easy access, never have to worry about the hassle being asked for care, because a lot of those patients, the funding that they get can't be transferred to us. But we do that philanthropically as part of our mission. And what other diseases do we say? I mean, I can speak a little bit from my personal experience. I'm a pediatric ophthalmologist in the real world, and we have done these vision screening clinics all throughout Oklahoma City and the metro area, and we've done some in the counties to the south of us. And we do encounter there are a lot of tribal kids there. And one of the things that we have been noticing over the last several years is that we're not likely to see kids with diabetic retinopathy, even though few have diabetes, but the incidence of amblyopia and strabismus is much higher in children of patients with diabetes. And so we are able to target them for the screening and identify these cases earlier. And again, we have the same setup here. All those kids that fail the vision screening, we work with the schools or the tribes or the local cities to get transportation for them to come see us for a full eye exam. We might do a full day's worth of these kids who failed screening, and we take care of them at no cost. So that's been very rewarding.
And the funding source for all that support, Dr. Siatkowski, is it governmental? Is it from your eye institute's general clinical productivity? Is it philanthropic or a blend of those? I mean, that seems like a real challenge I hear about.
It's a blend. Yeah. It's definitely a blend. The DMEI Eye Institute doesn't receive any direct federal or state money for care other than just for Medicare, Medicaid. So it's been out of operations or out of philanthropy that we can get that done. But that's also one of the reasons why in 2026 we're going to develop an integration with the OU health system and actually become their full-time department of ophthalmology. So that will allow us to continue to do these outreaches on an even larger scale.
And do you have some goals? Or, I've met Dr. Fairless. She'll be obviously a great champion going forward. Do you have goals over the next 5 or 10 years to expand or grow this program? Or it seems like you're already performing so far.
We do.
So well,
we are actually we're trying to hire another retina specialist so that he and Libby can split this task. We want to go. I mean, our goal is that no patient with diabetes should go a year without an eye exam. Okay, and we need to figure out how to get that done. Partner with local optometrists, maybe telemedicine, and then be there for the people that need treatment. So we really want to develop a scale where everyone's getting in this funnel, and there's this group at the top. Maybe it's not deaf, but it's the people that referral warranted. We want to be able to get all the people in that funnel that need to be, and we want to be there to take care of the people referral warranted, whether it's watch and wait or treat now.
Interesting. Really, really commend you for your work. I've seen a lot of folks try to do this kind of work and really haven't found your success. I guess I have a question for both of you, maybe starting with you, Dr. Parker. You both have commented on the relationships and the trusts and really following through and people that you trust recommending the program versus, some kind of generic presentation of the program is really being the key to getting people to invest significantly to where the program might succeed. So I guess my specific question for you, Dr. Parker, is, as national leaders on this front, have you been or would you be open to other tribal nations kind of visiting you and learning from you and talking about this program? How has that gone in the past, or might it go in the future?
I think that's a great question, and that most definitely we all work together. So as you probably heard me talking about the Tribal Leaders Diabetes Committee, that came from all of the 12 areas, IHS areas. And so we meet together, we talk about programs. And so it is a great opportunity, and it is things that we do share. We talk about best practices. And so most definitely that's something that happens.
Very good. Well, I'm sure we could spend a couple more hours on this, but we're at the end of our hour. So I'd like to thank both of our wonderful presenters today. Thanks again, Dr. Siatkowski and Dr. Parker. I think I'll be calling you myself, and I know a few other folks would love to learn more from you. So congratulations on your work, and thank you for participating today, and congratulations on the award.